Well, before John comes up to conclude, we've got our final presentation and panel discussion. We're going to do it slightly differently. I'm going to introduce the presenter, and then he will introduce the panelists. In May 2013, John, Lars, and I were on the hunt for commissioners. And I happened to be visiting Haile and his group in UC San Francisco, and I wanted to learn about their MSc in global health. And I said, can I sit in on a class? And I sat in on a class. And that class was given by Gavin Yamey. And I thought, whoa, this guy, we need to get him on as a commissioner. And I think that was probably my greatest contribution to the commission. But it's a pleasure for me to introduce Gavin to you. Gavin is the head of Evidence to Policy Institute at UC San Francisco. And he, at the time when I met him, was just writing up the Investing in Health Commission, which was a very, very big commission for the Lancet. And so we had lunch together, and I learned about the commission process. And I got on the phone to Lars and John and said, hey, we've got to get this guy on board. And I think you both said, yes, okay, Gavin, come and present.
Thank you, John. You make me blush. So there seems to be a big competition right now for who's the most neglected specialty. So I'm going to claim that the policy people like me, we are the imaginary pet chihuahua of the imaginary friend of the neglected stepchild. So huge thanks to the Commission for inviting me to share the results of the Financing and Economics Working Group. I know it's the end of the day, energy levels are low. Let's see if I can at least convince you that this is exciting, important work. Let me just begin by framing the next 10 minutes. This is arguably the most important year in living history for global health and development. We're coming to the end of the Millennium Development Goals era, and soon we will be entering the Sustainable Development Goals era. And if you look at the current draft of the SDGs, probably not going to change very much. You'll see that surgery is totally critical, totally underpins many of the goals. Sure, the health goals, they call for a 2/3 reduction in maternal deaths, a 1/3 reduction in injury deaths, can't get there without surgery. But also because surgical conditions are pauperizing, impoverishing, we're not going to really reach the poverty goals either. The goals ask for an eradication of extreme poverty. That's living on less than $1.25 a day. Eradication of extreme poverty by 2030 and a halving of all forms of poverty. And I would argue that the Sustainable Development Goals right now are a utopian fairy tale. They are a fiction without surgery. I mean, some of us think they're a fiction anyway, but that's a whole nother debate. So, what do I do, by the way? That one. Oh, you're lovely. Marvelous. You've heard earlier today that the cost of scaling up surgical services, if we were to scale them up at the rate that Mongolia scaled them up, would be around $350 billion over the next 15 years. That might give some of us sticker shock. I'm going to try and persuade you otherwise. That's not a lot of money in the grand scheme of things, and it's certainly not a lot of money when you look at what would happen economically if you don't scale up. If you don't scale up, low and middle income countries are going to experience $12.3 trillion in economic losses. So you need to weigh the two against each other. And over the next 7 or 8 minutes, I'm going to dig into a few of those issues in a little bit more detail. I'm going to lay out what the policy problem is right now. I'm going to share with you some of the proposed policy solutions from the Commission, and then very quickly lay out a sort of a 10-point plan. 5 points for governments themselves to consider, and 5 for the international community. So, you know, I'm a physician, I'm a public health guy. I am very comfortable arguing for the scale-up of surgery for public health reasons, for moral reasons, for equity, justice, and ethical reasons. Very comfortable. But I also find myself in my day-to-day work trying to persuade decision makers to invest more in health. I spent last week briefing EU commissioners and European parliamentarians. Next week I'll be in UAE talking to the government who are getting more into global health. And they are more persuaded by economic arguments than by anything else. Luckily, the economic case for investing in surgery is very strong because the conditions have a large macroeconomic impact, the treatments are highly cost effective, and right now, the costs are mainly paid for out of pocket and are impoverishing. I want to just go over those three things in turn. So you saw this slide briefly this morning. This is a study by Blake and his team that shows what would happen if we don't scale up surgical services. This is a value of lost economic output study. Essentially, you're looking at lost GDP from the depletion of the labor supply and capital stock. And that's this $12.3 trillion number. That's mostly cancer and injury. And what you see in this picture is essentially another way of representing it, and that is in the actual lost GDP. And if you look at that top red line, that top red line for policy folks and economists is really stunning. And it shows that by 2030, lower middle income countries will be losing almost 2% of their GDP from surgical conditions. That is stunning. That is absolutely stunning. There was a game-changing paper in the malaria world by Gallup and Sachs that showed that malaria was knocking 1.3% off the GDP of malaria-endemic countries. And that really was an extraordinary game-changer for the malaria world. And it led to a huge rise in both domestic and donor spending on malaria. And I hope that this 2% figure will lead to a similar trend. That's the value of lost economic output. But GDP, it's a useful metric, but it doesn't measure everything. It's really just measuring productivity, the so-called instrumental value of being healthy and being alive, right? How much productivity do you have? But health also has an intrinsic value. We generally like being alive. We generally value it. In fact, Americans value their life at about somewhere between $5 and $7 million, you'll be pleased to know. And there are economic methods for valuing each additional year of life, the value of a life year. This is the intrinsic worth that people place on being alive and healthy in and of itself, nothing to do with the GDP. And we use this approach as another approach to seeing the sort of economic losses. And in 1 year alone, globally, economic conditions caused $14.5 trillion in lost welfare, of which $4 trillion was in low and middle income countries. Surgical treatments are a best buy in global health. It is incredibly distressing to have been at the global health table for the last decade or so, and you keep hearing that surgery is a luxury, right? We have to do this other stuff first. When we've got the other stuff out the way, then we can afford surgery. Tiffany Chow and her team have shown that that's, frankly, totally misguided. That many surgical interventions are equally as cost-effective as the classic best buys of global health, like childhood vaccinations, anti-malarial bed nets, antiretrovirals. And that doesn't even take into account the economies of scale that you get from platform effects, right? In the real world, if you're a decision maker, it's very unlikely that you will be deciding on scaling up just a single procedure. You are much more likely to be thinking about a platform. Once you've got a platform in place and your initial outlays have been taken care of, staff training, capital outlays, and so on, you get economies of scale. And Haile Debas, the spiritual godfather of global surgery with us here today, not godfather in the sort of Cosa Nostra sense, but the godfather to us all in this movement. In DCP2, the second volume, in a really game-changing paper, showed that a platform of surgical services delivered in a first-level hospital, a district hospital, would be highly cost-effective, costing just $33 per DALI averted in sub-Saharan Africa. So I hope I've made the case that there is a strong economic rationale for investing in surgery. And now I want to pivot to looking at the way in which we treat surgery right now from a financing point of view, which, quite frankly, is extraordinarily weak. There's a strong economic case for doing it, and yet we do it very poorly. The way in which we finance surgery, the way in which those finances are coordinated, the way in which the systems themselves create barriers and inequity and poverty, and even the way in which we pay providers. I want to briefly take you through that. First of all, we've heard quite a lot today about out-of-pocket expenses. They are pauperizing. They are pushing 33 million people every year into poverty, catastrophic expenditures, spending more than 10% of their total income. That's about a fifth, roughly speaking, a fifth of all cases of catastrophic medical expenditures in the world are from accessing surgery. But wait, there's more, because that doesn't even take into account the non-medical costs of accessing surgery, transport, food, and so on. Those costs push an additional 48 million people per year into poverty. So high rates of out-of-pocket expenses, highly impoverishing. The way in which we fund surgery is a bit of a mess. So we have some public sector financing, and that's from taxation and social insurance. We have mostly private sector financing, mostly out of pocket, a little bit of private insurance, and then perhaps a little, it's a bit unknown, external financing in the forms of grants from donors and concessional loans from development banks. But the rather tragic, rather appalling reality that, I said this at the London launch, and I mean it. I mean, yes, I sometimes am a bit overly dramatic, but this issue, I think I said drama queen last time, didn't I? Yes, I do get accused of that by my wife, but this issue should really be something that keeps us up at night, along with worrying about pandemic influenza. This is the other thing that I think should really disturb us in the global surgery movement. We have no idea at all how much financing there is for surgery. None. And I've had some experience working in the global maternal and child health world, and they are leaders in actually tracking how much financing there is. So we know how much is needed to prevent maternal and child deaths. And every year, the Partnership for Maternal, Newborn and Child Health commissions a detailed study, incredible study, to find out exactly how much financing is flowing. So we know the size of the gap. We can't close the gap in global surgery because we have no way of quantifying it. So the databases that track development assistance for health, the fancy term for health aid, they don't track aid to go towards surgery. Lily Gutnick led a small project where at least we just dug into the financing of one donor, the US government, looking at US-based NGOs, their tax receipts, looking at records of the NIH, USAID, and even then we weren't really able to get a full handle on total US spending. We could see that NGOs mostly focus on elective eye surgery and cleft palate through short-term missions, USAID and NIH mostly on fistula and trauma research. But in terms of the global donor community, we're a little bit clueless. Similarly, as John mentioned this morning, there are only 2 countries in the world that track how much they're spending domestically. We know from this extraordinary work of the Institute for Health Metrics and Evaluation that tracks aid for health that the last decade was a golden decade, a tripling of aid for health. Probably surgery wasn't in there, but we're just not sure. The bulk of payments, as I said, are out of pocket. They're a barrier to accessing surgical care. When you remove out-of-pocket expenses, you see surgical service uptake goes up, not surprisingly, and these expenses are regressive. They place a higher burden on the lowest income people. And on top of user fees, there are also other fees, the costs of surgical supplies. In some countries, patients or their families have to pay for gloves, sutures, and so on. And the costs of transport and food, as I mentioned, can be impoverishing, even when the treatment itself is free. We argue in our report that there's a much better way that I hope the panel is going to get into of financing surgery, and that is through prepaid mechanisms, where target the target users, if you like, that's the general population in this case, they are making regular contributions either from taxation or insurance into the pool, and then when a member of the pool is sick, treatment is paid from that pool. So the payments are spread out, it's much more equitable, it's much more efficient, and it provides financial risk protection. And John talked about the reasons why that kind of system is far more effective, far more equitable than user fees. User fees don't work because of the nature of surgery, surgical conditions. They're life-threatening or limb-threatening. You have to have treatment quickly. You don't know when it's going to happen, and the fees are catastrophic. And lastly, the way in which we pay for surgery right now is dominated by what's called input-based purchasing, where the government simply pays inputs over and over and over, where they're not linked to the quality or efficiency of the service. And there is a trend now towards more strategic purchasing, where at least you link some of your payments to higher quality, which in turn, in some studies, is associated with quality improvements. Not surprisingly, our policy solutions are linked to those problems. We call for a scale-up of both donor and domestic financing. You'll remember that $350 billion figure. It's about $23 billion a year. That is less than, in fact, that is much, much less than 1% of the expected economic growth of low and middle income countries from now to 2030. So if countries themselves show political leadership and are willing to devote a small percentage of their economic growth, much of this could come from domestic financing. Certainly we want donors invested at the start, but a lot of it could come domestically. We need to track that financing. We need to adopt these prepaid mechanisms, and we need to introduce at least an element of strategic purchasing. And that has led us to a sort of 10-point plan, very briefly, to ensure that policies towards universal health coverage cover surgery early on, that there are no user fees, that we use prepaid mechanisms, that domestic resource mobilization is going to be key. National health accounts should track spending, and strategic purchasing should at least be experimented with as a way to improve quality and efficiency. Those are recommendations for governments. And lastly, for international collective action, yes, there should be donor support. We are going to need aid to kickstart the scale-up. We urgently need to start tracking donor assistance for health. Donors should support that tracking effort both globally and nationally. They could help spearhead financing for countries to track spending. And lastly, something we haven't said a lot about, but we certainly did say a lot about in the Commission on Investing in Health, donors should support R&D, 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 and R&D. It's one of the most powerful forms of international collective action. So hopefully that sets the scene for our final panel of the day. And with that, I would like to ask our two panelists, Vanessa, Kerry, and Robert Martin, to come to the podium or table. So whilst they are coming to the table, let me introduce our two panelists. Vanessa Kerry, founder and CEO of XII Global Health, director of the program in Global Public Policy and Social Change. Here at Harvard, she has an MSc from my town, the LSE in London School of Hygiene and Tropical Medicine, and is a critical care physician. And Robert Martin, who's at the Rockefeller Foundation, manages relationships with grantees, has been working on the Transforming Health Systems initiative and coordinating the foundation's post-Ebola efforts. He has a tremendous resume of working with all sorts of fancy organizations listed there, and has got, various masters as well, also from London. Marvelous. Nice to see my city represented. So over the next 15, 20 minutes, I wanted really to dig into the kind of two buckets of funding, the two buckets of financing that I've mentioned, donor assistance and domestic financing. The latter of which, by the way, I think is going to prove to be more important and more resilient. Let's start with donors, and a nice segue, I think, from the conversation just now about media and global surgery. Can we persuade donors to step up to the plate? How can we do so? What is it going to take? Is it the kinds of stories we just heard talked about? Is it data? Is it the return on investments? What is it that you think, and there's a question for both of you think could work in persuading donors that this is a global health issue? Vanessa.
First of all, good afternoon. Thank you very much for having us here. And I do recognize we're at the end of the day, but we're going to solve all the world's problems right now, right, all together as a group. So I look forward to this conversation. And it's, this is a question, it applies to surgery certainly, but it applies to everything. And I think that it's interesting that you laid out all the financing discussion, because the truth is the financing argument really is the most powerful argument for many aspects of donor aid and for many aspects of mobilizing, just to jump the gun a little bit, governments to be able to invest internally. And I think that therefore recognizing it as a powerful, much, when you look at the way the governance works in many of the countries that we're worrying about, or resource-limited countries, there's often a Ministry of Health, a Ministry of Higher Education, and a Ministry of Finance, and there's a complex interplay between all of these institutions. But the Ministry of Finance certainly, I think, has a very strong influence on what is going to happen. And so when we talk about, how are you going to mobilize these funds, I think that, and as presented in the report, there's going to need to be an investment from external funds to jumpstart it. But it is a very powerful investment. And I think that the anecdotes and I think the stories and the data are very much going to drive it. And there's a really important, I think that is one of the most powerful tools that we can bring forth. And so perhaps the prerequisite to getting more funding is going to be to take the work that everybody in this room is doing and to begin to actually systemize it, record it, and use it as a powerful tool of advocacy for this kind of funding. And I can just give an example. So I run this organization that sends doctors and nurses abroad to be medical and nursing educators with the idea that we will train the next generation of skilled health professionals and make that investment in these countries. I have an OBGYN that we sent to northern Tanzania, and within 6 hours of being at her site, somebody knocked on the door and said, "You have to come to the operating theater immediately." She went to the operating theater, and there's a pregnant woman on the table who was clearly, it was too late to save this woman or her children's life, and she lost all three. Turns out the woman was pregnant with twins. She was very devastated by this, and the next day she was called back to the operating theater with a very similar situation, in a woman in distress on the operating table, had been in labor for 3 days, and had effectively ruptured her uterus, damaged many other organs, and she realized that she had the opportunity to save this woman's life through her surgical intervention of an emergent hysterectomy. She saved this woman's life, and this woman has 5 other children at home, 2 of which were under the age of 2. And we know that women who are mothers who die and have children under the age of 2, those children are more likely to die. They're also more likely, and any children of a mother who dies is more likely to be socially disadvantaged or to be in poverty growing up. And so it's a vicious cycle that just gets perpetuated. But through one surgical intervention, that vicious cycle got interrupted. And there's a whole potential not only for this woman, but for her family. And I think that those types of stories can be incredibly powerful and compelling. But the data that you've pulled together in this report is something that we should all be carrying forth as we are investing in our programs or we're making arguments to governments. And so I think that it is driven by data. I think it is driven by the economic argument. But I also wouldn't underestimate the emotional toll. And this plays a little bit off of, the media and how you really, emotional stories go a long, long way. And we are, many people who work in this field, and certainly for surgeons, we tend to be very clinical and very focused, but do not underestimate the power of the emotional argument.
Thanks, Vanessa. Robert, you are a funder. How are you viewing surgery, surgical scale-up, the opportunities there?
Sure. Thanks, Gavin, and thanks so much for the invitation to be here. Many, many congratulations to the commissioners and the Lancet. It's a tremendous report. I think, looking at this and considering the question, that there's good news and bad news here. I think the good news is that surgery needs to be a part of universal health coverage. And I would argue, I'm not sure it's quite sexy, but I think universal health coverage is a politically palatable and appealing way to focus on health system strengthening. And I think, as the Commission argues, and I think has been said again and again, we really need to see surgery as an integral part of health system strengthening. It's not one or the other. They're not at odds. They're very much, aligned. And on that note, I mean, we begin to get into the bad news, which is I'm really glad the Commission talked about the 3 delays for surgery, in terms of seeking, reaching, and receiving care. And they borrowed that model from maternal health. This is where I think the kind of bad news begins to blossom. It's not just for surgery. It's not just for maternal health. It's actually for most health services, if not all health services, we have the 3 delays. You have delays in seeking, reaching, receiving care for every health service. This is the same thing, the bad news, going back to your presentation here, Gavin, with the financing. All of the problems that you laid out for financing are not unique to surgery. Again, that is the situation for all health services. The majority of health services in Africa and Asia, and the developing emerging economies, are paid out of pocket. That's a problem. We know that economies are growing. We know that spending on health is growing. They're very closely correlated. I think there's a P of 0.95. So we have growing economies. We have growing spending on health. The problem is that most of that spending is being done out of pocket, which we know is regressive. We know is further entrenching poverty and creating further problems across economies. So I think we have to think about what makes surgery special, what makes it particularly worth focusing on as a part of health system strengthening. And I think, Gavin, the numbers that you gave, we know that around 150 million people every year suffer from financial impoverishment due to medical spending. 32 million out of that 150 is because of surgery. When we take non-medical impoverishment into account, the number goes up to 81 out of 150 million. That means more than half of the impoverishment from medical impoverishment is coming from surgery. That's a huge fact. That's a huge number, and I think it should lead us to focus more on surgery as a part of health system strengthening for universal health coverage.
Can we just stay on UHC for a minute? Because the UHC movement certainly has caught fire. My last count, at least 70 low and middle income countries have signed up for UHC. They said they're going to do it. And I think that we would love to hear, you've been really part of that. The Rockefeller Foundation has spearheaded that. What are the lessons from the movement building of UHC that you think the global surgery movement can learn from?
Oh, thanks, Gavin. It's a great question. It's something. As I was reading the commission and preparing for today, I kept thinking, wow, this is so similar to the discussion on universal health coverage. And the foundation has been engaged in this space since about 2008. And when we started talking about universal health coverage, we heard again and again, this is unrealistic. This is idealistic. It's too expensive. People can't do this. This is pie in the sky. And so I think, now we're at a point where we're talking about universal health coverage all the time. It's in every commission. It's at the kind of forefront of the global health agenda. It's firmly enshrined within the Sustainable Development Goals. It's something now that I think is seen as feasible and inevitable. And I think we can get there with surgery too. I think there's 3 or 4 lessons in my mind that stand out that are applicable. I think one, and this report begins to do that very well, is really identify and address the challenges head on. And in this case, I think the financing is one of the big challenges. It's the elephant in the room. And so being clear and honest about that, I think, is really important. And I think this report begins that discussion. The second thing, and again, the report begins this, is highlighting country examples and country champions. We've heard today from a number of countries that have made great progress. I think we need to highlight them more, profile them more, and show that it is possible to focus on surgery and make great improvements there, that it's not financially impossible. We need to also empower country champions so that they can kind of, again, showcase and profile their work. We also need to highlight positive deviance, and I think the report begins to do that. And then finally, I think there's a need to kind of link to other movements. So I think surgery is beginning that with the universal health coverage movement, but I think it needs to do that with other movements within health. The NCD movement, the HIV movement, there are links and overlaps between all of those groups. I think something that we've learned over the last 10 years in global health is we can't every few years jump from disease or issue to another. It's, we can't have a kind of disease or intervention du jour or du year. Every other year, we can't create a global fund for every issue. We need to think much more holistically.
Thanks, Robert. Vanessa, so you and Agnes Binagwaho, Rwanda's Minister of Health, Paul Farmer, and your team wrote a brilliant chapter in my book called The Handbook of Global Health Policy, available at no good bookstores that I know of, but I think you can find it on Amazon, which was called From Aid to Accompaniment, the Rules of the Road for Development Assistance. And it's, if anyone wants a copy of that chapter, just email me and I'll send it to you after. It's really an extraordinary chapter. Can you give us a sense, accompaniment was mentioned this morning, but kind of how might this apply to global surgery and even to the financing of global surgery? What is it and what are the principles that could apply here to financing global surgery?
This has really been the work of Paul Farmer. I think this idea of accompaniment. This has been something that he has worked on his whole life. It's been a way of being, frankly, that he has always manifested, and I think that he has built a culture of among those that work with him, which is critically important. And it's the idea that you are journeying with those that you are partnered with and you are helping. You are not coming in patriarchally, you are not coming into the solution, but you are on this walk to better health, to poverty reduction, to building a program that provides a better solution together. And it's really based most fundamentally on this premise that it is the priorities of your partner that matter most, that should be driving the agenda, and it is the successes of your partners and the local community that really need to be measured. And so when we talk about accompaniment, I mean, there's sort of 8 core principles that are outlined in the chapter, but the first and foremost is actually that there should be a strong investment in the public sector. Because the public sector, believe it or not, though it's not a perfect system, but when possible, we should be focusing on the public sector because they are in the best position to be accountable to their citizens. It is not ideal. We can all give examples where it's not, but in truth, they are the ones that are accountable to their population. An NGO is not. It is the idea that we should be really focusing on listening to those that are most affected by the problem. Because the truth is, when you're living day in and day out with a problem, you're probably thinking about what the best solution is for you. So you've already thought about it, you just might not have the resources or the capabilities to actually execute on that solution. And that's where you as the partner can probably come in and help do that. But to come in with a solution that you think is right based on your own analysis without having actually really been embedded in that experience, it's very difficult to know that you're going to get the solution, to sort of be efficient about coming about the solution. I think it's also the idea that, when we talk about the public sector as well, just going back to the public sector piece, it's the idea that also they're in the best position to possibly integrate across all these NGOs and different partners that are coming in. Again, not a perfect system, but we know it is possible. Rwanda has shown us that capability. Liberia is increasingly gaining that capability. There are numerous other countries where you are beginning to see that, depending on the capability and the strength, and I think that we have a responsibility to participate in that process as well. We should be using job creation or local capacity as our benchmark of success. So it's not just about the lives we've saved through surgical procedures, but have we trained somebody to be able to perform those procedures on their own so that this is a sustainable solution over time, where they are capable of performing these procedures, they're capable of helping to execute and lead this response. Because that brings us from the transition of, we talk about making this initial investment of foreign funds to probably get this off the ground, but that's not going to be the long-term solution. We are going to need this to become a country-owned process, but we need to all be universally invested in seeing that actually take place. It is also, I think it is the importance of us as citizens to engage in sort of regulation of these non-state partners. I mean, one of the phenomenons we've certainly seen is that NGOs, while they can be beneficial, can also be very disruptive, because they can not only come in with their own agenda and sort of way of being, but they can pull from the public sector. There's internal brain drain. They can pay more, provide higher salaries, which can undercut the entire system. And so we all have a universal responsibility to really try to support the regulation of that. It is a somewhat parallel system, unfortunately, and we need to help try to make it integrated. So again, everything is country-led. And this is really the idea of accompaniment. As it applies to surgery, it's exactly the same concept that as we are tackling these solutions, we need to adhere to these principles first and foremost as we go in to try to partner to improve surgery. And I think it is going to be critically important, because some of these solutions are not going to be driven by what we know and do here. We have a very different technology base, we have a different training system, we have a different set of problems, frankly, that we might see here. And so it is going to be very important when we ask some of these sorts of questions that I think, and come with these solutions, that we take this approach. And so, I think accompaniment should be, it's a way of being, though. It's a mentality. But what's really critically important about accompaniment, too, is that it's not going to be in 2 or 3 years. We have to be really honest in this room that the solutions we're seeking to have are going to take 10 years, 15 years, 20 years. I know that sounds horrible, and I don't mean, but that should be exciting, because it means that we actually, if we commit ourselves to that, we change our expectations, we change our time frame, and we have the power actually to then change the funding streams as well. And so and to demand from those that are funding that they be patient with us, because to really see long-term change, you got to be in it for the long haul. But that's a mentality change that we all have to commit ourselves to and all demand differently.
Thanks, Vanessa. So great to hear a robust defense of the public sector. Honestly, I'm in so many global health conversations where it's time to start thinking of private sector delivery as the only way forward, and it's very frustrating. So it's just lovely to hear such a robust defense. So John has asked me essentially to kind of wrap it up in a minute or two. So we're going to take one question. It's going to have to be a really great, pithy, punchy, short, compelling, the pressure is on.
From the microphone.
With an incredibly short answer from the panelists. And my taxi comes at 4:15 in 3 minutes, so I literally might be out the door during the answer, but we'll see. Go ahead, sir.
I'm Colin McCord. I have a distant connection to Columbia University, and I've worked in several developing countries. Question. You have said that finance is the elephant in the room, and I certainly agree with that. But there's another elephant, or there's a side of the elephant that hasn't been discussed, and this is corruption and distortion. And I put the two together because really, in these countries, with these terribly low salaries that people generally receive in the public sector, the corruption is not just dishonesty, it's also we need it for our family, And distortion is not legally corruption, but the doc who got his free education and training from public funds and then devotes the rest of his life to private practice in the big city is certainly distorting the system. So that's my question. What can be done about this? To what extent can an external force have any real influence? Because it is basically an internal problem. But to what extent can the external actors have a role in this?
I will try to do this in very quick terms so that you can also answer. But I think you're right. This is this is a very significant problem. And I am a big defender of public sector, actually, despite all of those problems within the system. And the two are very related, because if you're not paid your salary, you're actually obligated to work in the private sector in order to ensure that you can feed your family, you can send your kids to school, you can make ends meet. And so the system is somewhat broken. But I think that, again, you have to be careful, because you can't make the lump sort of assumption that everybody in the public sector is operating on that. And if you're careful and you think about who your partners are on the ground, and I see this all the time with SEED, we work at 13 institutions and 17 sites, and our partners on the ground are some of the most phenomenal, courageous, heroic mentors to me that I've ever seen, because they don't operate in that way, and they are very devoted. And then what I realize has become an issue is that it is my job to find a way to become the voice for those that are working really hard and don't feel like they have a voice at the level of a higher government. And so I think we have a responsibility as a partner to try to wield influence as we can, to be vocal and to set standards. I mean, we want to do good and we want to partner in these places and we want to do work, but if you are not being met by the country or the site or your partner in this partnership, maybe you shouldn't be working there. It's a really difficult thing to ask yourself. But I think that ensuring that we also require everybody to have some skin in the game in the same way and to be accountable to this can help raise the bar for everyone. And I think equally, by committing ourselves to training good folks and showing that we're in this for the long term, and committing to training some younger folks who can rise up and then fill those positions, we can also change kind of the rules of the game over time. But again, it's a long-term, I think, commitment to pushing out what has been the tradition and creating a new set of standards to come forth. I don't know if you want to.
Yeah, Vanessa, I think that was great. There's not much to add, but I would say, I think it's a very tricky question, and I think, corruption and distortion is not only something that happens on the other side, I think it happens on this side as well. And we need to be honest about that as well. I don't like having a conversation kind of us and them. I really think it's all of us together, and how can we do better on both of these challenges. I think, we need more money. We also need to get more results for the money that we have. And I think we need to pursue both at the same time, and I think we can all do better. So thank you for the question.
Panel, thank you very much. Robert, thank you, and thank the Rockefeller Foundation. We really appreciate it. And Vanessa, thank you for flying directly from DC here. She landed, got in her car, and came right here. So that's devotion to surgery. Thank you. All right, so please make yourself comfortable.